Welcome back to Physio Vibes. In this video we are going to look at
Scaphoid fracture and physiotherapy management.
Before we start, hit the subscribe button for more videos. Press the bell icon and never miss another update.
Scaphoid fracture and physiotherapy management. Scaphoid fracture is more common in young adults. It is rare in children and in elderly people. Fracture scaphoid accounts for 60% of carpal injuries. Mechanisms of injury. Two mechanisms are described. 1. Radial compression and dorsiflexion occurring at the wrist. During a fall on an outstretched hand generally results in an undisplaced fracture. 2. Hyperextension occurring at the wrist during a fall on an outstretched hand generally results in displaced fracture scaphoid. Undisplaced fractures are less complicated than displaced fractures. Classifications. Based on Mayo classification. 1. Fracture of the tuberosity. 2. Fracture of the distal body. 3. Fracture of the waist. 4. Fracture of the proximal pole. 5. Osteochondral fracture. Based on Russ classification, the fracture scaphoid is classified as I. Stable. 2. Unstable. All displaced scaphoid fractures, irrespective of the nature of the fracture line, are considered as unstable scaphoid fractures. Horizontal, oblique and transverse fractures are considered as stable fractures when undisplaced. Clinical signs that help in diagnosis. 1. Tenderness in the anatomical snuff box. 2. Tenderness over the scaphoid tubercle free element, 1989. 3. Scaphoid compression test chain, 1989. 4. Painful limitation of movements of wrist and thumb. Investigations. Radiological features. Whenever suspected, an oblique view of the wrist, in addition to the anteroposterior and lateral views, is essential. Sometimes, it is just a crack fracture and is not visible on initial X-rays. If a fracture is strongly suspected, X-rays should be repeated after 2 weeks. Treatment. Non-operative. It is employed in undisplaced and incomplete fractures. A special cast known as scaphoid cast with wrist in 15 degrees of dorsiflexion and 5 degrees of radial deviation is given. The cast is maintained for 3 weeks in fracture of tubercle, for 8 to 12 weeks in fractures of waist proximal pole. The position of immobilization is sometimes described as glass holding position. Operative. Is employed in displaced fractures. Closed/open reduction and internal fixation done using special screws, for example Herbert screws, Accudric, scaphoid screws, etc. This helps in early mobilization and functional recovery. Physiotherapy measures for scaphoid fractures. During immobilization, exercises to involve joints to maintain ROAM is given. The vigorous movements are given to shoulder, elbow, hip joints. To aid circulation at fracture site, resistive movements to the fingers elbow are given. During mobilization, after the plaster is removed. In case of tubercle fracture, no specific physiotherapy is given, or is needed as fracture heals in 3 weeks of immobilization. In case of fracture of waist proximal pole, resistive exercises to free joints are given to aid circulation. To reduce pain after cast removal, ultrasound, TENS or hot pack are given. Mobility exercises are started to thumb to cause mechanical effects stimulate mechanoreceptors. As the period of immobilization is long, so chances of stiffness are prevented by relaxed passive mobilization with resistance. To regain full functional capability by hand, Routine hand function exercises are done. In 5 weeks after removal of cast, strong movements of wrist are regained.
Thanks for watching. Don't forget like, share and subscribe.